And I want to just express to you my appreciation for actually devoting an hour on a Monday night to learning a little bit more about one particular dental treatment repertoire that, in my opinion, is really underutilized in our industry. And that's this idea of implant overdentures. And I'm actually really looking forward to talking to you about them. So before I start, I want to thank first Catapult for giving me a platform to speak about this, and then also Implant Direct for sponsoring this meeting and bringing this particular course to all of you. Now, I want you to all know that all of my handouts, everything that I speak on, whether it's implant overdentures, whether it's any of my practice management stuff, I keep all of my handouts in a very high-level form on my website, BeBetterSeminars.com. If you go on my website and you go to this tab right here that says handouts, you can download any of the handouts that I speak about. And I don't ask for your email address. I don't ask for a membership. There's no fee for it. You can just download any handout that you want and use it however you like. And so this particular presentation about implant overdentures, there is a handout for this, but then also on the Catapult platform where you registered for the class, that same handout is available. One thing that I just want to make clear to everybody is that whether or not you find this hour to be useful or not, you're going to find the handout to be useful. And so let's say in 6 months, you get your first implant overdenture case and you're like, dude, I kind of forgot some of the stuff that this guy talked about. Just print out the handout and I think you'll find it very helpful. Okay, so what's an implant overdenture? Let me just teach you what it is, okay? So imagine in a edentulous space, whether it's fully edentulous or partially edentulous, there's an edentulous space that has something called a locator emerging from the gingiva. So in this picture here, you have a fully edentulous upper arch, and you have 4 locators that are permanently emerging from the gums. They've been torqued into some dental implants, and they're permanently emerging from the tissue. In this picture over here, this is just another view, but it's the same exact thing. Edentulous arch with locators emerging from the tissue, and those locators are semi-permanent. And then the inside of the denture has something called a retention cap, and that retention cap snaps into the locator that's coming out of the edentulous space. Okay, so hopefully you follow me. There's edentulous space with locators sticking out of the gums, and then there's these retention caps that actually allow the denture to snap in to that locator. And that allows the denture to snap into a fixed, stable attachment. And because the denture now is getting its retention from a fixed attachment, it reduces the need for the amount of vestibular extension or palatal extension in order to attain retention. You know, when we were in dental school, we learned how to make a denture retentive. And that was, you know, in the upper arch, we wanted it to have enough extension in the palate so that it would create a suction. The problem is that not all patients want full palatal coverage. Not all patients want full vestibular coverage. And so this allows for the elimination of some of that coverage. This is just an upper denture here that you see where I shaped it as a horseshoe-shaped denture so that it would snap into the locators. It would get its retention that way. And then the other thing is, if we're getting our retention from the implant locators, that means we get to eliminate or maybe mitigate the need for clasps around natural teeth. And that's great because clasps are ugly and they're terrible and they ruin teeth. And so in this picture right over here, where you see my thumb, that's actually where the tooth would be in this denture. But instead of a clasp going around and clasping onto that tooth, there was no clasp that was in the design of that denture. And instead, the retention cap on the inside of this denture snapped right into a locator. So it's kind of nice. And what's really nice about this is that patients love it.
For the first time.
I ate corn on the cob, first time in 2 years, and it was good.
This dude hadn't eaten corn on the cob for 10 years because he was edentulous. Now, I don't even think that's a very good denture that I made him. Look at the thing. It's not even like the midline is off. I feel like the plane of occlusion is off. The dude's happy. And the reason he's happy is because he can eat and he can function and he can do stuff that he wasn't able to do. I was able to make a disability become an ability. And the fact is that's satisfying. Whereas class 2 composites, crowns on 31, those are difficult, they're challenging, but they're not actually that satisfying because I don't get to have a dude tell me that he wasn't able to eat before and now he was able to eat. Why else are they nice? Well, gaining stable retention in a lower denture is just difficult. It's hard. Most lower dentures, no matter how good you make them, it's hard for them to have stable retention. And some patients just can't tolerate palatal coverage. Now, in this video that I'm about to show you, this denture that I gave this guy was immediately after I pulled all of his upper teeth. Okay, so this is his healing denture immediately after I pulled all of his upper teeth. Here you go.
What's wrong?
I just felt out there. There.
Is it hard to keep those in?
Is it?
Okay, I can tell it's hard to keep those in. Okay.
No, it's not that it was hard to keep those in. It was hard to keep this guy from gagging or throwing up all over my operatory. There's no way this guy long-term would be able to tolerate a full coverage, a palatal coverage upper denture. So either he's screwed or I have to give him a different option. So, and then of course with partial dentures, clasping is ugly and it ruins abutment teeth. And so in this picture over here, this patient is actually a young lady, a younger lady, and there's no way she was going to tolerate metal clasping on those two upper anterior teeth. And so we designed her partial where we didn't have any clasping on the anterior. And actually those posterior clasps that you see there, I ended up eliminating those, but I needed some posterior clasping for all of the try-in phases of the denture fabrication process. And that's why you see clasping in the posterior there. But I was happy. I got to cut those off, smooth them out because this lady was getting all of her retention just from those implants and those locators. And then I have to talk about this thing that's marketed so heavily, and that's all on 4, all on 6, long span fixed replacements. Everybody likes to talk about them. Dentists who do them love to brag about it. They're just like, dude, look at this sweet case. I jammed like 10 implants up there, and now this patient's super happy. Let me tell you about why I find these stressful. First of all, a lot of my patients, I work in a relatively middle, lower class, blue collar neighborhood. A lot of my patients wouldn't be able to afford a fixed case. The other thing though, is let's say they were able to afford a fixed case. Once I fully restore that case, those implants have to survive long-term. They have to. If one of those implants fails, I'm kind of screwed, and so is the patient. And what if the tooth breaks from my bridge? Or what if an implant fails? What if the gums recede? What do I do? And the fact is, it's easy for those things to happen because it's difficult to clean around and under. Here's a case that I did on a patient. And listen, this patient is super happy. She's super happy. Like, she loves me. She loves my office. She thinks I'm the greatest dentist ever, right? Because her teeth are fixed. She never has to take them out. She looks awesome. But let's look a little bit closer. Let's look a little bit closer still. This is the area around tooth number 14. And what do you see? You see threads that are no longer supported by her bony arch. What does that mean? Is that implant, unless she's unbelievably careful, and I'm incredibly thorough with my maintenance, that implant has a high chance of failing. And when that happens, what am I going to do? What am I going to do? Well, I'm going to have to like bust off that bridge and then make her a temporary of some kind. Then I'm going to remove that implant, bone graft it, place another implant somewhere else, then make her a new bridge. And when I do all of that stuff, is she going to pay for it? Probably not, because she unloaded a bucket of money when she had me do this original case. This case, while this patient happens to love me right now, this case really scares me. It stresses me out. And that's why I love these dentures, these implant retained dentures so much, because they make people happy. They make people love me, but they don't stress me out. And why else are these so great? They're very profitable. Now, I just want you to look at my fees. I don't charge anything for the surgical guide. I charge about $1,500 per implant. And in most cases, I place 4 implants in an arch. And then what I charge for the locators and the caps and the housing is about $250 per. And then the immediate denture and the complete denture, these are my fees. Now, I think a lot of you are looking at that and you're like, whoa, dude, Gupta, you're so cheap. I might be. I work in a particular suburb outside of Cleveland. It's in an area that is about where the rural Ohio starts. And I feel like my fees are fair to where I practice, but I know that they're very low. But despite the fact that my fees are low, every time I do one of these cases, I'm making a lot of money. These are very, very profitable. So what do we got here? They're satisfying, they're less stressful, they make patients love me, and they're very profitable. Why aren't more dentists doing it? People are really happy when you provide them with this particular solution. All right, Daryl, tell me, how do you like your lower dentures?
I like them. They work real good for me.
Yeah, try to take them out. All right, now snap them back in. Oh, let's see the hardware. Let's see the hardware. Let's see those implants in there. Open.
I didn't use those.
Yeah. Okay. All right, now snap them in. There, I heard the snap. Is there anything you can't eat?
No. I can eat anything I want to eat. I can eat anything I want to eat.
That's great. It's so satisfying. I mean, I've done endos in which I found the MB2 canal. My patients don't care if I found MB2. They don't care if I found that extra accessory canal. They don't care. They don't care that my margins are super sweet on a crown. My anatomy is like, they don't care. This guy cares. I feel like I did something very good. I feel like I did something that in which I got to really serve a person and serve. So let's do it. And I think the answer is actually quite easy. I noticed that one person actually has entered a question in the Q&A. Whoever you are, I will make sure that at the end of this lecture that I go through all the questions in the Q&A. And so I don't want to ignore any of the questions that are asked. So why don't all dentists do it? Well, I think the big reason is there's lots of parts and pieces. And we didn't learn about any of those parts and pieces in dental school. There's little parts and there's little parts that go inside other parts. And then you have to special order this part. And then this part attaches to this part. And that's what, there's so many little parts and pieces. And it's tiny and they're complicated. And some dentists just don't really want to take the time to learn them. A lot of dentists like me hate dentures. Implants are intimidating and people don't know where to start. And that's actually one of the big reasons why I decided to devote today's class to these things. I want to make it so that you realize that, yes, there are parts and pieces, but you can make sense of them. And they're no more complicated than a lot of the other things that you do in dentistry. So my goals for this course. Now, because I'm here for an hour, I will not be discussing surgery. Implant Direct is one of our sponsors for this course, and it's the Implant Direct implants that we often place for this particular surgery. I won't be talking about those implants. However, all the parts that are purchased that restore a denture, those locators and retention caps, etc., those are offered through Implant Direct, okay? So I won't be talking about surgery, but what I will be talking is about how you go from the moment a patient comes to your office with healed implants in an edentulous area all the way to the time that you snap in that denture. So the surgery is super awesome. It's planning and executing the surgery for these types of cases is just so awesome. It's so satisfying. It makes you feel like such an awesome dentist and clinician. Since I won't be able to talk about it today because of time constraints, I want to make sure that all of you have an opportunity to mark your calendars. Monday, April 3rd of next year, same time, 7:30, we're going to do a 1 hour lecture that goes through all of the details of surgically planning a case and all of the details for all elements of surgery in doing one of these implant overdenture cases. Okay, so the surgery is done. The surgery is done. The implants are healed. They are, nothing is emerging from the tissue yet, except for maybe a healing cap. Now it's time to attach the locators, adjust your interim, fabricate your final denture, and maintain those implants around the denture. So in this case, I had this patient here. Because of financial constraints, he wasn't able to do both his upper and lower. I'm going to walk. The majority of today's lecture is going to be walking through his particular case. I do want to point out, okay, do you see this implant right here? This one, okay, well, I guess I would call it number 10. It looks so good, right? It looks sweet. Well, anyway, when that patient came back and it was time for me to remove those cover screws from his implants and replace them with locators, I found those implants and I started unscrewing the cover screws and one of my implants came out. It failed. I still don't even know how. I don't know what I did wrong. But anyways, does this stress me out that this implant failed? No, it doesn't really. Because this case is going to restore beautifully. It's up to the patient whether or not he wants me to place another implant in the future in that area because I kind of owe him one. But I don't care. Neither does he, because his upper denture is going to be horseshoe shaped and it's going to be retained very, very well from those 3 implants. So how do we make the denture? Well, you can't start making a denture until you put in your locators. And there are people on this call, there's about 200 of you that are on this call right now who have heard me say the word locator a few times, and you're not quite sure what a locator is. Let me explain what it is, okay? So these are locators. Every single thing that you see on your screen right now is a locator. And that would intimidate the heck out of me. If I saw that, I'd be like, dude, I don't want to do this. This too, I don't have the brain. I'm not smart enough for this. Let me make it easy. First of all, this part that's down here, this silver part on the bottom of all of these locators, determining what to order, what that silver part will be shaped like is simple. The silver part of your locator is determined by your implant brand, line, and size. So if you place a Implant Direct legacy implant that's got a 4.2 millimeter diameter platform, all you got to do when it's time to locator is tell your salesperson, hey, I need a legacy 4.2 diameter platform locator. So that is determined by your implant. Next, the salesperson's going to be like, yo, I got those, but what is the cuff height? And I'll explain in the next few slides what a cuff height is. And the cuff height is what I'm pointing to with this arrow. It's the length of this cylinder that separates the silver part of the implant, which is determined by your implant manufacturer, from the top part of the implant, which is identical for all locators. The top part of your locator is identical. This is the part that snaps into the retention cap. And if you notice that all these mismatched different shaped locators, they all have the same top. The same top, meaning that any retention cap that goes into a denture is going to snap into the top part of your locator. So what is a cuff height? Well, once you remove your healing cap, you're going to notice that there's distance from the height of the gingiva to the platform of the implant. And that distance, if you were to measure it with a perio probe, is the cuff height. And so that's how you determine what cuff height to tell your salesperson, whether it be at Zest or whether it be at Implant Direct. You're going to say, I need a cuff height of 2 millimeters or 3 millimeters. What I would tell you is that if your perio probe shows something between 2 and 3 millimeters, always round up, and I'll explain why. So sadly, a lot of cuff heights, they don't come in like 1.2 and 1.6, and it's usually 1 millimeter, 2 millimeter, 3 millimeter, etc. Those are those cuff heights. And you're always going to round up. Let me explain why. Because a lot of times when you remove your healing cap, you're not going to have a perfect depth all around that gingiva. It's going to be long in some places and short in other places. That's almost 100% of the time when I do these cases. If you notice, the perio probe is at about 3 millimeters in this picture that you see there on the left, 2A. But if you move that perio probe to the other side of that dental implant, it's probably only about 1.5 millimeters. Always round up. Always use the longest length. If you see here, the lingual cuff height is like on the left side of your screen. So on the patient's right, that lingual cuff height is probably 4 millimeters, but the buccal cuff height might be only 1. Pick a 4 millimeter cuff height. And I'll explain why in a second. But before I do, I want to explain what you do once you get your locator. And see, Zest, which also is a supplier for Implant Direct, they're the OGs when it comes to locators. They're the ones that provide a lot of these locator parts. And they also provide a lot of the tools that make this easier. And if you look at number three there, that's called the actual locator driver. And what it does is it allows you to snap in your locator with your fingers and place your locator inside a person's implant, inside of their mouth. Then you would use a normal torque wrench to actually tighten it in place. Okay, so here you have locators that have replaced the healing cap and they're coming out of the gingiva. And if you notice, they're not perfect. And they're never going to be. Like the one on the right side of the screen looks different than the one on the left, but they're both perfectly satisfactory. Let me explain why. Because here I measured the depth of the cuff height to be 2.3 millimeters. Now that means that I was going to order a 3 millimeter locator, okay? Because I always have to round up. I'm going to order a 3 millimeter locator. And so that means it looks pretty good coming out of the tissue. 3 millimeter locator cuff height. And it looks like, all right, not super bad coming out of the tissue. And then what I do is I take a metal housing. This is the thing that will eventually be picked up by your denture that's going to snap into your locator. So I take a metal housing and I snap it into my locator. And here are the rules that you want to follow. When you snap in your metal housing, ideally, you wouldn't want to see a lot of locator. You would want to see very little, but you also shouldn't see any of your metal housing pinching the gingiva. And if you look on the top of your screen, which I would call the distal of this dental implant and locator, you can see that my metal housing is slightly pinching the gingiva. That's going to potentially create a problem because now every single time that person snaps their denture into place, there's a possibility that they might be pinching their gums every time they do it. What ends up happening actually in a lot of cases is that I err on the side of seeing too much locator so that I don't have too much of my metal housing that's going to be buried under the tissue. This, if you notice this picture here, this really sucks because this is the same locator. It's the same locator. It's the same site. On one side, I see too much locator, and on the other side, there's too little locator, and some of the metal housing is under the tissue. Yes, it's not perfect, but the fact is, even when it's not perfect, it's okay. If too much of the metal housing is buried under the tissue, the housing, it might be hard for you to pick it up in your denture, okay? Or it might pinch the patient every time they snap it in. Now, if too much of the locator is showing, meaning if you over round it up, well, you have to remember, the lab has to make an entire denture that fits around that super long locator. And so what could happen is that your locator that you chose is too long and you end up creating a hole in your denture. In this case, this is my healing denture. I created a hole in that healing denture to accommodate that super long locator. You know, in this case, this one right here, this was actually not a situation where my locator was too long. This was actually, I placed my dental implant a little bit too far to the buccal in this particular case. And to be honest here, I was too overzealous in trying to fit a locator and a metal housing in that particular denture. I should have used just a smaller abutment and soft relined around it because There was no way I could fit all of those component parts and still have this denture not have a hole in it. You know what really sucks about this picture is this was the day I seated the this was the brand new denture. Can you imagine brand new, several $1,000s, and there's a hole in this stupid thing? I don't want you to have to make that same mistake. Okay, so next you snap in all of your retention in your metal housings and retention caps. You snap them all in, and now it's time for you to take your first impression. Okay, so you picked your locators, you snapped in your metal housing, and you can take an impression for your final denture. Let me just go through the terms one more time. And this is why I spend so much time with my, handouts, is I want my handouts to be sweet so that you can look at a slide like this and be like, yo, there's no way I'm going to remember all this crap. Fine, don't remember it. It's all good. My handout is very high level, and it's going to show all of these parts, what they do, what they're for. Okay. But I find this pretty helpful. Locator is the brass colored thing. That's the thing that's sticking out of the gums. The locator placement tool, that's this brass thing at the bottom of the screen that allows you to finger tighten your locator. A locator driver is something that attaches to a torque wrench that allows you to fix your locator in place. A retention cap is the nylon removable thing that snaps into the locator and also sits inside of your metal housing. The metal housing is a permanent part of the denture eventually. It's the retention caps that you get to change as they wear over time. I'm hoping that all of this makes sense. See, my team, my dental assistants, I do a lot of these cases. I do a ton of these cases. And so you would think my dental assistants would like know the terms really well. You think, right? I mean, like they're my dental assistants, and I'm like bragging about how I do a ton of these cases. Watch
So
them.
in here, we have lots of different implant parts. I'm gonna lay them all out. Okay, now, here they are. All right. Okay. Let's see. Oh, let's flip over the ones. Okay, let's see how fast you can do this. I would like an open tray impression coping.
Oh, that one.
Got it. Open tray impression coping.
Yeah.
Oh, you got it too.
Yeah.
Okay.
Yeah.
All right.
There were two.
All right. Ready? I need an implant analog. You got it, Kathy. Okay, very good. All right. Next, I need a retention cap.
Wait. I don't. I was trying to say.
Oh, yeah. Okay. There's this one right here.
See, and this is like my team. I'm supposed to be bragging about this kind of stuff. It's really hard to keep track of all the different parts. And so what I want to do is make it very easy for you. Please, if you do these, print out the handout, laminate the page with that is a glossary of all the parts, and just keep it with all of your implant locator stuff. It'll be such a nice favor you could do for your team. All right, so you've attached the appropriate locators. Next, the problem is that your denture doesn't fit your interim denture, your temporary denture. It's no longer going to fit because you have a bunch of metal things sticking out of the gums. So now you have the underside of your temporary denture that the patient still has to wear while you are fabricating their permanent denture. So what do you do? Well, I like to use a combination of ink stick and articulating paper, and sometimes I use bite registration, and I put it inside of the denture. I try to seat the denture, and then I see what gets marked so I know how to adjust. Now, until I learned about this particular Burr and Polish kit from Zest, this is also available on the Implant Direct catalog. I used to use this gigantic football-shaped burr to adjust the underside of my healing denture. But what they've made is an actual burr that has the exact dimensions of a locator and metal housing complex. And what that allows me to do is remove just the right amount of acrylic on the underside of that denture so I don't over-remove, and it's a lot less frustrating. This is still a very sucky part of the process, but this is a little bit less frustrating. So in this picture here, these diagrams that come from the manufacturer, they're too cute. It never looks this good. But in this diagram here, they put PIP, pressure indicating paste, inside of the healing denture. It marked very beautifully with perfect circles. And then they took the locator shaped burr to create holes to now accommodate the locators that are permanently merging. Here I used some of that ink stick.
And then don't do anything with it.
Of course, doesn't fit. It doesn't fit, but what it does by using that ink stick is I can see areas on the underside of the denture, the intaglio surface, that need to be adjusted. And I can use that burr now to basically cut a perfect hole inside of the denture. So it's going to accommodate the locator without over demolishing the inside of the denture. Okay. So now you picked the right locators. Your interim now fits. So at least the patient can leave your office with a smile after you've torqued those locators into place. By the way, this first appointment, the appointment where a patient goes from having healing caps in their edentulous space and a healing denture to now having locators emerging from the tissue and an adjusted healing denture. This is a longer appointment. In my office, it usually takes between 60 and 90 minutes. It's a long appointment, but it's worth it because now I'm in no big rush to fabricate that denture because the patient is still able to wear their healing denture. Okay. So now you have an interim, it fits okay, and your implants are integrated. So what you want to do next is snap in your metal housings, and you can take an impression or a scan. And I'll explain the benefits of both. After you take your impression, you can remove those metal housings, keep them in a little bag, and keep them with the patient's case for the rest of the fabrication process. See, now that you've added those metal housings, the interim, your healing denture is going to fit poorly again. So you just remove the metal housings, keep them in a labeled bag, and then you can pop in that healing denture, okay? The reason why, though, you need to make sure that you snap in your metal housings before you take your initial impression is because the lab needs to start fabricating your denture base with enough of a hole blocked out to eventually accommodate not only your locator, but also the metal housing. Put that responsibility on your lab's shoulders. Put it by you putting the metal housings in and then taking the impression, the lab now knows how much room they need to block out when they fabricate the framework, when they fabricate the record base for your denture. Okay, so let's talk about, okay, so just to reiterate, take an impression with the metal housings snapped in, then remove the metal housings, put them in a bag, and then you can reline your interim denture. Now, why should you take your impression with the metal housings in place so that the lab can have enough room to accommodate that, all of that hardware that's going to be emerging from the tissue, okay? Now we need to talk about fabricating the permanent denture. Of course, if you want to make a denture the traditional way, make it the traditional way. Snap in your metal housings, take an impression, send it to the lab, and ask them to make bite blocks and wax rims and a record base, just the same way you've been making dentures ever since dental school. But the one thing that I would what I would recommend is if your patient likes the aesthetics and contours of their interim denture, what you can do is actually take a wash impression of the inside of your interim denture and then do a 360 scan of the denture. So let's talk about this. So my patient, she liked the way her teeth looked with her interim denture. So I took light body PVS from Kettenbach. I squirted that into her interim denture. And then I took a 360 scan. And by doing that, I was able to skip a ton of steps Now I can actually ask my lab to go straight to the try-in. And in some cases where patients are really impatient, I've actually asked the lab to go straight to the fabrication of their permanent denture, which is really awesome. That's a lot of steps that we were able to save. And the contours of the teeth, the aesthetics, the occlusal vertical dimension are identical to the interim denture, which they were already happy with. The one thing that I'm going to tell you, though, is that it's too much of a pain in the butt. It's too much of a pain to relieve the underside of my healing denture so much to accommodate both my locator and my metal housing. So most of the time when I do a 360 scan, it's of a PVS impression of, here, you can actually see it. It's a PVS impression of only the locator in place rather than a locator in the metal housing. If I burrowed out so much room for the metal housing, I would have put a bunch of holes in her interim denture and she wouldn't have been very happy with me. Okay, so now you go through the same steps. For those of you who like to make dentures the traditional way, go for it. For those of you who decided to skip some steps and do a 360 scan, you go through whatever steps you do to make the denture. Most of the time, the reason a patient has decided to take on the investment of an implant retained denture is because they want it to be horseshoe shaped. And so I always ask my lab to metal reinforce the horseshoe shaped denture. And if you see here, the lab created enough room where the acrylic is to accommodate both my locator and the metal housing. So do all the normal steps. Make sure every time you try in your wax try-in or your bite blocks that the record base is seating fully and it's not being impeded by any of your locators. And then when you finally get your permanent denture, first, try in the denture, take photos of the bite, take photos of the person smiling, then snap in the metal housings, and then do the exact same thing. Make sure that the bite is identical before you snap in your metal housings and after you snap in the metal housings. If you notice here, this is a different guy. This was, I told him to lick his lips and relax after I tried in his upper and lower permanent dentures before I snapped in the metal housings. And this is how he looked. Then I snapped in my metal housings and I told him to lick his lips and relax. And then this is how he looked on the picture on the right. What does that mean? It means that one of the holes inside of my denture, one of those holes was not big enough to accommodate both the locator and the metal housing. I needed to take that burr and start creating more room to accommodate that metal housing. And the way I did that was by using the process of elimination, figuring out which one of my 4 locators was, when I in the metal housing, was it sticking out too much to prevent the full seating of my denture. And if you notice here, after I adjusted it, I mean, I was pretty close to popping a hole in that denture. And that's something that, you know, there are those of you clinicians here, you like it. You actually like popping a hole in the inside of the denture, and that's perfectly fine. What that's called is venting. And I actually don't like to vent. It's not because I'm like better than dentists who do vent. I don't like it because it just looks a little less polished in the areas where I vent. And I like it when my dentures look super polished. So anyway, I almost created a hole. And if I hadn't had my prep and polish kit, I definitely would have created a hole because my burr would have been so imperfect. So let's do this. We try okay, remember, patients coming in, they have locators emerging from their tissue. Try in your denture, make sure it fits up against the gingiva. It's still a soft tissue supported prosthesis. Now, with your denture stabilizing, with your fingers stabilizing the denture, have the patient bite down and take a picture. Snap in all your metal housings and then try the denture again and confirm that the bite, the smile, and the relaxed pose is exactly the same as it had fit before we snapped in the metal housings. Take photos. do a horseshoe shaped articulating paper to make sure that everything is identical. And if it's not, use the process of elimination. Just snap in one metal housing, see if everything's identical, and you'll find your metal housing that's a little too long. This is the most important slide to follow in order to prevent headaches in the future. So now you have your holes inside the intaglio surface of your denture. They can fit your locator and metal housing. You've already established that. So now it's time to pick up those metal housings. The metal housings have been snapped in place. And before I pick them up, I have to do two more steps. Number one is I have to create an undercut in each concavity, okay? So in those little holes that were created, I now need to take a burr. This comes from the same Burr kit. It's an undercut burr. And what it does is it creates an undercut inside of that reset. And what that'll do is it'll allow my hard pickup material to lock into those holes, okay? So I created an undercut inside of my denture, but what I need to do is block out undercuts that are under the metal housing. Now, one thing that I've done, I've been doing these for years. And one thing that happens often for me is patients who had regular implant, single tooth implants, they lost more and more teeth. And then I made them pivot from having fixed single tooth teeth, single tooth implants along with some crowns and bridges and whatnot. I said, let me pull a bunch of your teeth and we're going to make you an implant retained denture that's going to snap in and out. Well, the problem is these patients over the course of time, they don't do a very good job of taking care of their teeth. And therefore they don't do a good job of taking care of their implants. And if you notice, you're going to find undercuts. This guy, this is not like a very pretty case, but the reason that this guy's case looks like this is because he had a bunch of single implants over the course of the last 15 years. So what I needed to do was make sure I blocked out any undercuts that were under the metal housings. That could be adjacent teeth, the height of contours of adjacent teeth. It could be exposed implant threads. It could be anything along that nature. You can use a variety of things to block out those undercuts, because the last thing you want to do is lock in hard pickup material around undercuts inside of the patient's mouth. That's a pain that I don't want any of you to have to experience. I've experienced it a couple times. I won't recommend it. Okay. This is another wonderful pickup block outer. It's actually very similar to the material that people use when they protect the gingiva with in-office whitening systems. I think it's actually the same stuff. You extrude it, you light cure it, and what it does is it kind of hardens around those implant threads that are exposed, or an adjacent height of contour to a tooth, so that your hard pickup material can't lock in. Zest, they're the OGs when it comes to denture pickup. Zest is the provider for a lot of the denture pickup materials that are offered through Implant Direct. And they have a lot of really helpful tools. Okay, so I have my finished denture. There it is. It fits well. I already tried it in. And so it's time for me to pick up my locators.
And
I bled a little bit, confirmed a nice mix. I filled in those holes inside of my denture.
okay. And then take that, it's this, recording. Okay.
And then I actually squirt a little bit of pickup material over my metal housings, just because I want to be pretty confident that pickup material will find its way to actually pick up my metal housings. No air bubbles or anything like that.
Now bite you.
And there she is.
Come on, stay biting.
She bites for 5 minutes.
Excellent, 5 minutes, okay.
And then I come back. And all I have to do now is flick off a little bit of that denture pickup material. And just like your predicted, there's all this extra. It's kind of satisfying to pick that off. And then I polish it up. I'm sure there are some of you who ask why I don't vent. Venting would be a much easier way to remove excess acrylic in a case like this. I've just never really been happy with the polish around the vent hole, and that's the reason why I don't vent. It's not because I'm better. I don't disagree with anybody who does vent. I just don't, and I could easily be talked into venting. I've had good results without venting. Okay, so one more time. Trying your denture, snapping the housings, trying the denture again, add undercuts to the concavities inside of the denture, but protect undercuts around the implant, and then use hard pickup material to pick up the metal housings and polish.
So David, how you feel?
Pretty good.
Yeah? How do you like it?
I love these teeth.
Yeah?
I was able to eat a steak
You're
for the
getting,
first time in a long time,
that's really good.
and ate some Snickers bars too, which I couldn't do before.
That's okay. Once in a while it's okay.
Yeah,
Oh, thank you. I'm so happy. You're happy.
I'm happy.
Good.
And
And they feel wonderful. They do. I'm happy. Thank you.
I don't get that. For the majority of the dentistry that I do, I don't get that type of feeling of satisfaction. And that's why I recommend adding this to your repertoire so much. Before I finish and do the Q&A, I just want to emphasize that before the patient leaves, you let them know that that retention cap that's inside of those metal housings, that will wear out over time, and you should have them replaced every so often. On the same note, you know, these people, they lost their teeth for a reason. They lost their teeth because they don't take very good care of their teeth, and they're not going to take very good care of their dentures as well. And so what I would recommend is you ask your patients to maintain a pretty rigorous maintenance schedule. And that way you can check up on them, make sure that the implants aren't completely disgusting. You can clean up around them. And then you can change those metal housings. I'm sorry, you can change your retention caps so that the patient can kind of get a refurbished denture that's nice and snappy every time they visit your office. I do have certain patients that they really don't want me to replace their retention caps, just because these are older patients and some of them are arthritic in their hands, and they like it that it has pretty minimal retention. And you're going to find that there's a lot of patients in that same boat. Zest provides a lot of different style of retention caps. The three that you see on the left side of your screen, the blue, pink, and clear, those are the most common for the most simple cases. But if you have diverging implants, etc., what you're going to find is you're going to need some diversity in the retention caps that are available. And Zest is actually a wonderful resource for cases like that. One thing that is just starting to enter the market is something called Locator Fixed. And this is where you place a normal locator, but the retention cap and metal housing apparatus is so stiff that you can actually make a fixed case for the patient where they never take it out. And that's quite appealing, because then you can actually remove all of the vestibular concavities around the ridge of your implant, making your denture much, much easier to clean. Now, the reason I don't have any cases to show in which I highlight Locator Fixed is because this is a relatively new market, a product that has just entered the market, but I have the feeling it's going to be a real game changer for these implant denture cases. All right, it's 8:20. I promised you I'd answer your questions. So before I do, I want to let you all know that I do return emails. When people email me with questions, something that I take a lot of pride in is that I respond to those emails. I really do like to help people with this kind of stuff. I do have an implant institute where I teach dentists, especially dentists who are very unfamiliar with dental implants, very simple things about how to place implants, how to do very simple bone grafting techniques, and of course, how to restore single implant cases and implant dentures. And then I don't really do much with social media. I wish I did, but I do have a page that I hardly ever contribute to. That's that. Let me stop my share and ask and answer some of your questions. All right. Question 1. This comes from Ocean. Do you need a second set of locator halves for the final denture, and do you charge for them? So Ocean, if you're still on the call, I would like you to be a little bit more specific about a second set of locator halves. What I'm wondering is if you're talking about the metal housing and the metal housing and the retention cap. I don't know exactly what you mean, but if you don't mind just retyping the question, I'll try to give you an answer. Okay. Jim Jellin says, what dental codes do you use for the retention caps and the locator abutments? Jim, I actually believe that I included those in my handout. I don't know them off the top of my head. If you don't find them in the handout though, please email me and I'll send you those codes. Okay. Next one. How long are you waiting to allow the implants to be fully integrated? John, that's a great question. John Shapka. 6 months is the rule. However, I have patients, I use something called an ISQ or a penguin. It's something that tests the stability of my dental implants. For patients who I'm placing an implant in virgin bone, meaning edentulous bone that has not had a tooth there for a long time, that means that bone has pretty well healed. I will test the stability of that dental implant the day that I place it. And if it tests very stable, I will shorten the period. Some patients absolutely cannot tolerate their implant retained, I'm sorry, not their implant, their healing denture. And so I'm willing to fudge the numbers, but 6 months is what I always tell patients at the beginning when we first start treatment planning. SP Drive. There are specific impression copings to use instead of the metal housings for zest. Actually, SP Drive, that's a great point. However, I don't use them. The reason why is because what they do is they allow the lab to use a locator analog. And my lab bill goes, it's like, I thought I made your life easier, lab. And all you did is charge me like an extra $1,000 so that you could like pour up a model with locators in it. I have no use for that. And so I never use these specific impression copings. I never use them. And the other thing is those impression copings will show the dimensions of your locator, but they will not also communicate to the lab the exact dimensions of the metal housing. And so when I use those, the lab still, they're not going to create a large enough hole to accommodate that metal housing. I would rather just take an impression on metal housings. Anonymous attendee. Was that denture that didn't go down for Attain from a scanned impression? That was a great question. It was. And the reason it was because my scanned impression did not have the metal housing already attached. If you remember, my metal housing, if I did a scan of a healing denture with metal housings attached to the locators, I would have to drill a gigantic hole in my healing dentures. And I don't think that that would be comfortable for the patient to tolerate for the 4 or 6 weeks that they're dealing with their healing denture while I'm fabricating their permanent denture. And so oftentimes I have to adjust more at the time of picking up the permanent denture when I do a scan. Whoever you are, anonymous attendee, that was a great question. And I apologize that I didn't make that more clear earlier. Code for the metal housing. Jim, I'm so sorry. I don't know it off the top of my head. Now that I know that this is a pretty popular question, though, I'm going to make sure that my codes do show up in my future lectures. And And also I'll email it to you. If you send me an email, I would be happy to send you what codes I use when I go back to work tomorrow. Jim, again, how do you get the locator fixed out? Oh, it's actually, it's a little device that reminds me a little bit of, you know, that little tappy thing that we use to remove crowns. Like, you know, if you have a crown that you have to pop off, you can drill a little ledge in the crown and go ding, 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 and then the crown pops off. This thing is a little different. It has a rope, almost like a wire rope that you slide under your denture. And then it has like this little snappy thing that'll pop the denture out. So the patient's not going to be strong enough. You probably aren't going to be strong enough. So you use a little device that helps snap that fixed locator out. And that makes it great so that you can still do maintenance procedures very nicely with the denture being out. Hope, what was the purple material used during the pickup process? Oh, Hope, I know what you're talking about. Okay, I'm going to share my screen for just a sec. Hang on. I think you were talking about the rubber dam, and I'm sorry for not making that clear, but that's a great question. I'm going to share my screen. If I can wait. Where did my Zoom thing go? Share screen. Okay, Hope, you're talking about okay, that's a rubber dam square. It's a rubber dam square. And the reason I used it, Hope, is because I always use a blockout material around my metal housings so that the hard pickup material doesn't harden up around an undercut. And a rubber dam, a little square rubber dam with a hole, serves as a wonderful blockout material. Okay, sweet. That was a great question. Okay. Okay. Do you charge for replacements? Yes, but I charge $10. Whenever I replace a retention cap, I charge $10. And nobody cares. I don't think I've ever had a patient complain. Ocean, I did not realize the temp denture did not have locators in it. No, so my temporary denture is just a denture. It's just a traditional denture. Thanks, Ocean, for providing clarity. Okello, how do you determine the implant sizes to use? Do you go smallest acceptable or largest acceptable? Okello, please attend my implant surgery class that's going to be April 3rd. It's going to be offered through Catapult Education. Attend that class. And the reason it's so important that you do is because I will go through how I go through the process of determining implant size. I believe that the biggest, fattest, meanest, just juiciest implant has the best chance of integrating and having long-term success, long-term integration. So I usually use the largest one. However, a lot of times the decision of what implant to place is not only my decision, it's also mine and my lab techs. S. Kissinger, compare the standard locator versus the Locator RTX. The Locator RTX is another Zest product that allows for more divergent implants. And so a standard locator assumes that your implants are going to be pretty well parallel with each other. And that's not always going to be the case, because remember, sometimes you're pivoting to an implant overdenture solution. And those implants are going to be all jacked up. Using a RTX is actually a wonderful option when you have diverging implants. And the Locator RTX is it's a very nicely retentive option as well. Shireen, why not using the healing denture as a final restoration? Shireen, that healing denture is kind of gross. I don't know. I mean, like, I slopped that thing in there the day that I pulled their teeth or the day that I did their implants. I guess I'm just charging too much money. I would feel kind of jerky. Now, one thing I could do is pick up locators in my healing denture so that that patient has a nice spare. But I don't think I'll ever use the healing denture as a final restoration. I feel like I'm a pretty cheap guy, and that's a little too cheap for me. Dr. D. From, you're a really great speaker and educator. Thank you. Oh, thank you so much, Doctor. I appreciate it. I love compliments. So I love it. Even though it wasn't a question, keep them coming. Anonymous, how soon can you load the implant? 4 months? So the interim denture is covering the healing abutments? Yes. So I always tell my patients 6 months because I like to give patients the most realistic expectations as possible. And then if I want to fudge the rules and give them a denture, say in 4 months or less than that, then I become the hero. But I never like to tell a patient that I'm going to load their denture, load their implants after 4 months, especially if it's a little old lady with really weak bone. I'm not going to be loading their implants. I'm going to wait as long as possible for those implants to properly integrate. William Holderman, what type of acrylic used to seat retention caps? So the acrylic I use is called chairside pickup material by Zest. Let me type that answer. Chairside pickup. I think it's also called processing material. Both Zest and Implant Direct provide this particular material. Myint Shui, do you recommend use of metal skeleton to prevent? Yes. All of my horseshoe shaped, actually all of my implant retained dentures have a metal skeleton. All of them, 100%. I've broken too many dentures in my career. I've broken too many acrylic bases. I have a much, I sleep at night better when I have a metal skeleton. A great question. Thanks for a great webinar. Thank you, Jim. Thanks for the great questions. Okello, how do you determine implant sizes? I'm sorry. How can I get your handout? Anonymous. 2 ways. The Catapult platform that you registered on, it has my handout at the bottom of the registration page. And then also I'm going to type BeBetterSeminars.com/handouts. All of my handouts are available online for free. You don't have to do a membership or leave your email address. And Kent, have you ever utilized Blue Moose for bite registration recording? I love Blue Moose. I totally love it. I'm a big Kettenbach fan. I love Kettenbach. I think Kettenbach is, I love their PVS materials. I don't know what their version of Blue Moose is called Futar. And I think Futar is just a smidge better than Blue Moose. But I mean, they're all great. They're all great. I'm very loyal to Kettenbach. Okay, now I'm going to go to the chat now because, okay, can you see this? Thank you. Good food for thought. Oh, all right. Implant. I know you guys. Great info. Have a couple cases coming up. Awesome. Kent, email me if you have any questions, if you want me to walk you through any of your upcoming cases. Nicole, when is the best time to measure the cuff height? Is this a separate appointment to check? You see, Nicole, where you are. Is this a separate appointment to check for this so the appropriate cuff height can be ordered? Great question, Nicole. I break the rules a little bit. Because I'm the surgeon and the restoring dentist, I sometimes skip the healing denture process. I actually find my implant cover screws, and then I torque in my locators. And I think that doing that shortcut could get me in a little bit of trouble because as those gums heal, after I've lasered them away to put in my locators, all of a sudden my cuff height might be too long, and I've had to change it in the past. So Nicole, that was a very good question. Lou, healing denture inserted right after implant placement, would that affect implant healing? Not in my case, Lou. All of my implants are fully buried under the tissue. I'm perfectly confident putting my healing denture in. Let's see, to get your credit. Oh, okay, so this is you, Catapult. This is just an announcement to all of you. Go to catapulteducation.com and then find my course and then click continue at the top. Scroll down to course contents so you can fill out the program evaluation and get your CE quiz. And then you also can get my handout there too. If you have any questions, just email Lisa at catapulteducation.com. And then Lisa also indicated my email address, and I'm very, very open to those emails. Ray Sean, what laser do I use? I actually still use a diode. I know that I should use a CO2 laser. But I'm cheap and I'll probably buy a CO2 laser in 2023. But right now I use a diode. I use a diode laser from a very small company in Kentucky called the Beamer 780 or 980 or something like that. It's a workhorse for me. I use my laser quite often just for restorative stuff. Thanks. That was a good question though. I think, oh wait, no, we got another one. What roughly do you charge more for the metal base in the denture? No, I don't. I don't charge any more for the metal base. My denture charge is my denture charge. I charge about $1,500 for my denture. I know it's too low. I know a lot of you are like, what, you crazy? Listen, I think my life is perfectly comfortable. I don't really have a strong need to charge more than that. It doesn't make me better than anybody who's charging more. I just find this to be profitable enough without charging more. And then A. Cirilli, do you take the denture skeleton with traditional impressions or do you scan the intaglio surface of the treatment denture? So A. Cirilli, I did do a slide on that. I do both. Sometimes I take an impression of the edentulous arch with the metal housing snapped in. And sometimes I just take my healing denture. I do a PVS impression inside of it. So it captures the location of the locators very well. And I do a scan of the denture and the intaglio surfaces. Kent's question is, what lab do I utilize? So I love for all my restorative stuff, I actually love a lab called Dandy Lab. They gave me my scanners, which was awesome. But I like the metal skeleton. And so I use a lab in Cleveland called Roe Dental Lab, ROE Dental Lab, because they do a nice job with the metal skeleton. And I've decided not to do printed and milled dentures yet. I'm too scared of a denture breaking. If I were to do a printed or milled denture, I would probably ask my lab to fabricate 2 or maybe 3 dentures, pick up metal housings on all of them. And that way, if the dentures ever break and it's a weekend, the patient will have a nice spare. That way I'll be able to sleep at night a little bit better. So M Riyadh, you asked about 3D printed dentures. I think that they're fine. I think that they're going to get better and better. There's a place for them in the industry. I'm just nervous. And so I would want to have a spare. I guess the question is for skeleton fabrication, A. Cirilli. So your question is, the question, do you make the denture skeleton with traditional impressions or do you scan? I do both. I do both. When I scan a 360, I send my scans to Roe, or if I take an impression, I send my impression to Roe and they will make the metal skeleton and then they will make that acrylic base around that metal skeleton. Thanks a lot for attending. It was a pleasure. I really enjoyed this. Thanks, everyone. Have a great night.